We now move on to the oration session. And for that, I would like to call upon the chairpersons. Dr. Anil Kumar Virmani, who is the chairman, Indian Association of Clinical Medicine at Jharkhand. Dr. Govinda D, professor and HOD of Medicine at BMC. Dr. Ravi Kumar YS, who is the professor and HOD, Department of Medicine, JSS Medical College, Mysuru. We welcome you on stage, doctors.
At Novo Nordisk, we believe innovation is in our DNA. Whereby semaglutide is created using recombinant DNA technology from a living cell. Semaglutide production begins with identifying the gene of interest. This gene is cloned into a DNA vector and transferred into a selected host cell. Through carefully regulated cell culture and fermentation, the protein is expressed, followed by downstream extraction, purification, and into finished products. We ensure that the original rDNA strain is created and replicated systematically and maintained across the process to ensure batch consistency. Hence, biologics are engineered, not replicated. However, even small variations in the process or presence of impurities can significantly modify the structure, stability, biological function, or may lead to loss of potency and may trigger immune responses. Novo Nordisk's legacy of innovation is built on delivering purity, stability, safety, and efficacy. Precision and care extend through to robust last-mile cold chain delivery. And this confidence is backed by evidence. Semaglutide has been evaluated and tried and tested across more than 50 clinical trials. The original biologic semaglutide is approved in more than 75 countries, involving over 66,000 participants globally in clinical trials, with trust generated through 49 million person-years in real world.
Now we'll move on to the prestigious Y. Subbarao oration lecture. You know, diabetic patients with autonomic neuropathy, we have seen in our practice, they are presenting with silent ischemia, silent MI, and even sudden cardiac death. As practicing physician, how to pick up these cases very early, how to make a diagnosis, how to subject them for further cardiac evaluation, and how to go ahead with the procedural therapy and even advising CABG. To talk on this, so what we need is initial diagnosis ECG. So Professor Abhay Narain Rai is going to discuss case-based ECG scenario, how to pick up early diagnosis and treatment. Dr. Abhay Narain Rai.
Good afternoon to all of you. To introduce Dr. Professor A.N. Rai, he is the founder president of the Clinical Cardiodiabetes Society of India. And it was 20 years back when we were looking at only sulfonylureas and glucose, he had a vision that the time will come when metabolic disorders will be the epidemic of the day. And the time has come, and that time he formed a society that we must take a holistic approach to glucose, to cardiac, to renal, to hepatic, so that ultimately we are able to give benefit to our patients. And I'm proud to announce today that we have reached such a stage that this is the only society in our country which is going to have an overseas UK chapter. So this is a big achievement of Professor Dr. A.N. Rai, and this shows how dedicated he has been. Another thing I'll tell you, whenever he gives a talk, he likes to interact. And as you see, the topic is ECG-based discussion of interesting cases of diabetes. So when he's going to put up the ECG and ask question, I would request the audience to interact and give their answers so that he can then discuss. Over to you, sir, Professor Dr. A.N. Rai.
Can we have a round of applause? Can it be a little louder? So I would also like to call upon Dr. L. Srinivas Murthy so that we can first felicitate Dr. A.N. Rai.
Thank you, chairpersons. Good afternoon, August audience. Outset, I would like to thank Dr. L. Srinivas Murthy for honoring me and giving the opportunity to speak Vai Subbara oration. As Dr. Virmani has said, since it is oration, no questions are allowed, but since it is a case-based discussion, active participation of floor is very important because we are going to discuss the case based on the ECG finding. We are having the first case, elderly diabetic male presented with severe burning pain in chest with setting and restlessness in 3 hours. Came to AIMS emergency for admission and treatment. Before he could be shifted to ICU, he had sudden fit with convulsions lasting for a few seconds. His pulse was feeble and BP was not recorded. His ECG is given below. I would like to opine on the floor. What is the most likely diagnosis? I have not presented this case for acute inferior valve ischemia. This is very clear. Is there anything else? So, in inferior infarction, we always have, there is no P wave, so it is not a complete heavy block. For complete heavy block, you must have multiple P wave. There is no P wave, so it's a nodal bradycardia. It's a nodal bradycardia, but I'm not, what is the additional finding in this ECG? Oh yes, inferior, and there is a, you can say, posterior also, RV pattern there, but the most important finding, any other finding? Oh. Tall T-wave in precardial leads. Tall T-wave in precardial leads. This is a diabetic patient, and diabetes have kidney diseases. So is there any significant tall T-wave precardial leads? Hyperkalemia. This is very important. So inferior ischemia is there, but the tall T-wave, you can see the tall T-wave. And you can see the finding. What was the serum potassium? 6.2. So this patient had acute inferior ischemia and tall T wave in hyperkalemia. First there is a tall T wave, there is a flattening of the P wave and disappearance as bradycardia, which all the features this patient had. So this patient had two, one is acute inferior ischemia and second is hyperkalemia. So, which one is to be managed first? What do you think the cause was arrest? It was a hyperkalemia. It was hyperkalemia. This is a echo finding, confirmed the inferior ischemia. Patient was put on TPI and hyperkalemia was managed. This is medically. So he was given IV calcium, calcium nebulization, IV glucose and insulin, and in addition to dual antiplatelet and 80 milligram atorvastatin and thrombolizing, he was thrombolized by ready place. And we can see what is the next. This is the finding. Serum, what do you think is serum potassium has come to? 4.09. And the ECG has shown improvement. Still inferior ischemia is there, we have thermalized, since it was 3 hours, so we thermalized, you can see. But still there is some tall T wave is there, but bradycardia, nodal bradycardia, everything has. So what lesson we learn from this? You see, diabetic patients, as our honorable chairperson has said in introduction, they present with a silent myocardial infarction, ischemia, due to autonomic neuropathy. But they have multiple different features. And one of the features is that diabetes affects kidney also. And if there is a associated diabetes kidney disease, these patients may have hyperkalemia and both kidneys together. So this was the first case. Now my second case. ECG of medial diabetic male presenting as severe chest pain since 3 hours. What is the diagnosis? Again tall T wave. This is acute chest pain and tall T wave. What we call it? Hyperacute. And what is the other name of this ECG pattern? De-Winter pattern. De-Winter pattern. This is equivalent to actually equivalent to LAD involvement. It is equivalent to STEMI. And these patients are thrombolized. And this patient will thrombolized, and the De-Winter ECG pattern is anterior STEMI equivalent that present without obvious ST segment elevation. First reported by De-Winter in 2008. Key diagnostic feature of De-Winter pattern include ST depression and peak T wave in precardial leads. De-Winter pattern is seen in 2% of acute LAD occlusion. And post-thrombolysis, you can see QH, anterior STEMI, LAD involvement. You can see. So this is the De-Winter pattern. Both had tall T wave. I presented both two cases together. Both had tall T wave. One was of acute anterior STEMI and other was hyperkalemia. Again, 35-year-old diabetic male was admitted with history of weakness and giddiness since morning. His on-his pulse 40 per minute, BP 160 by 100. ECG is given below. This is a classical hyperkalemia. There is no doubt. This is a classical hyperkalemia. You can see severe bradycardia, tall T wave, characteristic hyperkalemia. There is no two opinion about this. But you can see serum potassium was very high. Now this patient was managed again for medical treatment, but he did not improve. And patient relative advice for dialysis, urgent dialysis, they refused. And what was the next complication? The patient developed this. What is this? Hyperkalemia, VT, but it is not a VT. It is in relation to hyperkalemia. What we call it? Sine wave. It is a sine wave due to merger of white QRA complex with widening T wave. It's a sine wave. It's a very serious condition. If you are not going to dialyze, patient is going to die. And eventually the patient relative agreed for dialysis and patient was saved. This is sine wave due to merger of, I've already told you. And the serum potassium in this sine wave was 7.7. Patient was saved after he agreed for dialysis. And this is the ECG post-dialysis. So, you could not, the dialysis saved the patient. So, no doubt differential diagnosis are VT. LAD diabetic male presenting with fits since 1 day. Diagnosis and management. ECG given below. It's a classical block. So there is a bifascicular block, isn't it? RBBV, left excitation. So actually RBB left excitation is left anterior block and PR interval is prolonged. So more or less a trifascicular block. But what is the most important? It is, there is a one term, masquerading bundle block. It is not a left ventricular block. We call it masquerading bundle block. I presented this case for masquerading bundle. What is masquerading bundle block? Masquerading bundle block are two types. One is limb leads, where there is a RBB pattern in the precardial leads and LBB pattern in limb leads. You can see there is no S wave. Absent of S. Normally in RBB there should be S wave in lead 1 ABL. More or less there is no there. So this is the muscularity, it is higher degree of bifascicular block, and this patient will go into complete heart block and require urgent pacemaker. And this patient has fainting attacks. So we call it muscular bundle block. Diagnosis, it is standard muscular bundle block. RBB pattern in precardial leads, LVB pattern in limb leads. A small or absent in lead 1. There is also precardial muscular bundle block. RBB pattern in lead V1 to V3 and LVB pattern in V4 to V6 in precardial leads. This is known as precardial muscular bundle block. Have you heard the name of muscular bundle block? It's a diabetes, not a cardiology station. So most are diabetologists are there. So urgent pacemaker was there. Middle-aged diabetic lady presenting as sudden chest pain, palpitation, giddiness with sweating, as well since 1.5 hours. And she had feature of shock and cold limb with pulse and BP. Absent pulse and BP. ECG is not recorded. What is the finding? Yes. So diagnosis VT, DC shock, and post DC shock is easy, you can see. So patient may present with the VT, diabetic patient. This is a classical. Their anterior system you can see. Last case, elderly diabetic female admitted in ICU of MS with sudden palpitation and severe breathlessness since 4 hours. She gave history of breathlessness since 3 days. And this is the ECG. What is the diagnosis? Is it a VT or is it something else? You can see it is atrial flutter is 2 to 1 block. And you can see dilated heart. Dilated heart and arrhythmia. Echo confirmed that this is DCMP, diabetes with DCMP, atrial flutter is 2 to 1 block and heart failure. So this patient has diabetes, dilated cardiomyopathy, present with atrial flutter with 2 to 1 block. I'm leaving that. Thank you. Thank you. Because time is over.
Since it is a oration, questions are not allowed.
As it is, he has already asked so many questions.
Already 4 participation has been.
Thank you, sir, for a wonderful oration.
Thank you. Thank you.
Can we have a standing ovation?
Dr. L. Srinivasmurthy for giving us the opportunity to chair this session. Thank
Can
you.
we have a big round of applause? Can we? Thank you so much, everyone. From food for thought to food for the soul, we move for the lunch now, and we'll all assemble back at 2 p.m.